Hello, I'm Catherine Pettis, the IHPC Advocacy Officer, and this is the basic course on advocating for palliative care in the multilateral system. It's for our membership and for people who are joining so they can participate more. Why an advocacy program? It's a result of the survey of our membership, patients, providers, volunteers, board members, and funders. And it's in our 2020-24 strategic plan to, quote, prioritize advocacy for the integration of palliative care into primary health care within the spectrum of universal coverage and improved access to essential palliative care medications. And I'm going to unpack all those terms during the course of this webinar. So why an advocacy course? Why are we doing this? So that you, as an IHPC member, essentially as a shareholder in this global organization, can learn how the IHPC advocacy program is building our vision, which is a world free of health-related suffering, and participate in that, which is a way you can help advance palliative care in your own country, and also to prepare you for the advanced course if you want to participate more. This is going to give you an overview of our advocacy program, whereas the advanced course will teach you how to do it. And you will learn about basic multilateral advocacy terms and language. So some of these may be foreign to you, and I'm going to be defining them. Key institutions and meetings within the multilateral policy universe for palliative care advocacy, cornerstone multilateral documents that oblige governments to provide palliative care services, basic mechanics and challenges of multilateral advocacy, and the importance of partnerships and collaborations. Hopefully you'll walk away from this with a basic understanding of those things. So first, I'm going to start by defining the multilateral system, which is actually a term from international relations. And it's just a fancy way of saying international or global governance. But it's the context of everything we do. And its components, the components of the multilateral system are nation states, so governments, your governments, civil society organizations that are duly accredited by the United Nations, and business organizations. There are three main components of the multilateral system. And multilateral meetings are convened by UN organizations. These are the key organizations of the UN that convene the meetings where we advocate for palliative care. The UN General Assembly and the Economic and Social Council, which is called ECOSOC, and the main meeting I attend at the UN is the open-ended working group on aging. And I'll talk about that and how we advocate for a right to palliative care for older persons. The second is the World Health Organization, which is what's called a specialized agency of the UN, and I attend the Executive Board and World Health Assembly meetings, usually with a delegation which comprises members from all over the world. Then the Commission on Narcotic Drugs, which is in charge of all the medicines that we use that are controlled medicines in palliative care, and I'm going to discuss that. The International Narcotics Control Board, which oversees all the basic transactions of controlled medicines around the world, and the Human Rights Council. The second thing I want to clarify at the beginning is what our theory of change is. And a theory of change is the set of assumptions that explain both the many steps leading to the long-term goal, which, as I said, is a world free of health-related suffering, and the connections between our program activities and the outcomes we hope to achieve. So another way of saying it, which is clever, is if you're not at the table, you're on the menu, which is meaning that we have to show up for many of these meetings, whether we show up in person or we show up virtually on Zoom platforms or other ways that we can telecommute. Because often palliative care is forgotten, it's left out, and if we're not at the table, it will not be included. So there's this imperative of participation for advocacy. We can't just imagine it'll happen by itself because it's a good idea. So the assumptions underlying the theory of change are that palliative care is an element of the right to health. It's not a privilege. And rights in their very nature are universal. That means they apply to everybody and publicly guaranteed. They are guaranteed by the government. This calls for public policy, which entails political will, planning, and a budget. And then the other assumption that's important, that's connected, is that private and charitable services alone, which is how most palliative care is provided in most countries, cannot meet the growing need. Second set of assumptions is that global institutions matter. These multilateral institutions I just ran through set national and regional policy agendas for all of your countries because your countries participate in the global institutions. Language matters because palliative care language must be included in the multilateral texts that support national services. So in other words, if that language is left out of those multilateral texts, then you've got nothing to use as leverage with your governments to ask for services. And the third is that data matters, and serious health-related suffering has not been measured until now, which is one reason it's been so hard to advance palliative care, because you can't make arguments from data. Now we have it. And informed data use can help advocates hold governments accountable. And you'll find on the IAHPC website a map with data for serious health-related suffering all over the world and instructions about how to find your country and break down the data. So the basic definitions I'm going to go through are advocacy, palliative care, universal health coverage, primary health care, controlled substances, and then duty bearer, rights holder, agreed language, and spheres of influence. This should give you enough to get started on the global advocacy jargon. So advocacy is the act of pleading for, supporting, or recommending, from medieval Latin advocatia, the stem of advocare. You can hear that voc, which means to call, summon, or invite. The verb is to speak for another, from the Dictionary of Etymology. And a more modern definition from Advocacy for Social Justice is persuading people who matter to care about your issue, getting listened to, being at the table when decisions are made, being heard by people who make decisions. And this is our board member, Dr. Ebtisam Ahmed, who is a palliative care pharmacist, speaking at a meeting at the United Nations about the need to ensure access to palliative care medicines. She is advocating there for that particular topic. There are certain legal aspects to advocacy, which you can also tell from the word advocate, which is related, which often means lawyer. Even though advocacy isn't necessarily a legal process, it relies on precedent like law does. In other words, we always refer to existing international law and conventions. That's the context for our advocacy. We call witnesses as much as we can on our delegations to testify, and those are patients, providers, and families, to testify to the value of palliative care in a health system. And the third is that we argue from evidence. We don't just say this is a good idea, nice people do this. We talk about serious health-related suffering and the data thereof. So the next definition we're going to talk about briefly is the consensus definition of palliative care, which was developed by the IAHPC and more than 800 participants in 2018. Palliative care is the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. There are several other components to the definition, and if you want to read those and look at the methodology behind that definition, please see our website. Now, for the universal health coverage definition, this is very important because it's very political right now in the United Nations, and it now includes palliative care, which was a big advocacy win for our community. The spectrum of palliative care, the spectrum, of universal health coverage now includes palliative care, which it didn't before. So the definition, according to WHO, is that all people and communities can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. In other words, if you have a catastrophic illness, you will not be driven deeper into poverty or pushed into bankruptcy, but those services will be provided, basic quality services, in a way that you can afford it. It's a very hot topic at the moment, which is the balance between public and private funding. How much will the government fund? How much will the private sector fund? Universal health coverage and palliative care were the subject of a high-level declaration at the UN, which was approved by all member states, your countries, in September of this year. It's also the subject of Target 3.8 of the 2030 Agenda for Sustainable Development, which is healthy lives, healthy people, attainment of universal health coverage, which, as we've just seen, now includes palliative care. Primary health care is another definition which isn't the same as primary care. Its main focus is equity and its whole of society approach that includes health promotion, disease prevention, treatment, rehabilitation, and palliative care. Another advocacy win because palliative care was left out of some of the original documents for the primary health care declaration. Primary health care meets people's health needs throughout their lives. So from conception to natural death, it addresses the broader determinants of health through multi-sectoral policy and action. That's important because it includes the commercial, economic, and social determinants of health and environmental determinants of health. It's not just about clinical practice. It includes primary care, but it also includes an equitable approach that includes the whole of society. Just a quick definition of equity, which is different from equality, which is why I like this particular graphic. It's the quality of being fair and impartial. This one is equality, so you can see they all have an equal box to stand on if they can stand, but they can't all see over the wall. Whereas this is equity, where you can all see over the wall because their condition has been adjusted to. And equity means that policies take in all ages, income groups, diagnoses, ethnicities, and marginal groups. So it's this quality of universality that applies also to rights, as we saw earlier. It's a rights-based perspective based on an ethic of solidarity. So that's primary health care, and the fact that it includes palliative care now is very important for advocacy. And we had a big advocacy win last year in 2018 in Kazakhstan at the Global Conference on Primary Health Care, which took place as part of the 40th anniversary of the Alma Ata Declaration, which first established the right to health care, but did not include palliative care. Now, 40 years later, the high-level declaration did include it, and this is our delegation. Definition of controlled substances. They are plant-based or pharmaceutical preparations whose manufacture, possession, and use are regulated by governments under international, regional, and national laws to promote and protect public health. And they include what are called drugs in common parlance that are used illicitly, illegally, and it includes prescribed essential palliative care medicines such as opioids, which is one reason it's such an issue to advocate for palliative care medicines, because they are controlled substances just as illicit drugs are. And people often confuse them, especially using the word drug, which in common parlance includes both. And this topic will be addressed in detail in the advanced course. So I'm just going to be talking about the main institutions for controlled substances, and then we'll go into detail on advocacy in the advanced course. So this was a big win on controlled medicines in palliative care advocacy in Vienna at CND, which is the Commission on Narcotic Drugs, which originally, I would say before 2014, there were almost no side events or what are called parallel events or high-level panels on access to controlled medicines. Now we have several high-level panels at the meetings in Vienna. The documents used to have 2 or 3 lines on drug policy relating to controlled medicines. Now we have an entire chapter with practical recommendations, and we have a technical guidance on improving access to internationally controlled essential medicines. There's a synergistic partnership of civil society practitioners such as IAHPC, government representatives, and international civil servants. So we've come a long way in 5 or 6 years on advocacy for improved access to controlled medicines at the Commission on Narcotic Drugs. This was part of our delegation this year at a side event with several board members and staff. This is Dr. Nala Gaffer from Sudan and Dr. Rosa Buitrago from Panama, myself, Heloisa Bragiato, and Elizabeth Matfield from the United Nations Office of Drugs and Crime. So this is a real progress we've made in access to controlled medicines and advocacy. So here are some of the key concepts. Multilateral, which we've already discussed, the system constituted by UN member states. Duty bearers are the UN member states who have signed conventions and approved resolutions that include access to palliative care. And then rights holders are individuals who can make legitimate claims against duty bearers, their governments, to say you need to provide palliative care because you've made that commitment. You have a duty to do that. And the rights holders in the case of our advocacy are patients and families with palliative care needs. And again, this concept of equity, which primary health care reduces. Inequity. Primary health care reduces inequity. So other key concepts are agreed language, which are publicly available text documents that all UN member states have agreed on through a consensus process. A very intense process to get agreed language, but once it's agreed, then it is the language of the duty bearers towards the rights holders that you can leverage in your country to develop palliative care policies. Another important key concept is spheres of influence, which is the field or area in which you or an organization or a stakeholder, which is another jargon term, that field where you have power to affect events and developments. That may be your university, it may be your ministry, it may be at multilateral meetings such as IAHPC attends. Each of you has a sphere of influence, and it's important for you to define and understand what it is. So now we're going to discuss IAHPC official status in the multilateral community, which we now all know what that means. And I said we have to have official status as a non-governmental organization to participate, and we do have that status. And this is our sphere of influence. So first of all, the UN concept of civil society. It's the third sector of society along with government and business. This is from the UN Charter. And it says the UN recognizes the importance of partnering with civil society, organizations such as IAHPC, because that partnership advances the organization's ideals, the UN's ideals, and helps support its work. It means we have agency in the multilateral system. We can act and accomplish things. That's the concept of civil society. And all the national and regional palliative care organizations are also considered civil society organizations. They may not be accredited by ECOSOC, Economic and Social Council, but if you're members of IAHPC, we represent you at the UN. So we have, as I said, consultative status with ECOSOC, that's the Economic and Social Council of the UN. In order to get that status, the program of work of the organization must have, quote, direct relevance to the aims and purposes of the UN. So this means that palliative care has direct relevance to the aims of the UN. It has, the organization must have authority to speak for its members, a democratic and transparent decision-making process, and our basic resources must be derived from contributions or other components, which usually means grants. The other status we have in the UN system is that we're a non-state actor, that's the technical term, NSA, in official relations with the World Health Organization. This brings with it benefits and obligations. It means we can participate in the WHO Executive Board meeting, the World Health Assembly, and the regional meetings of WHO. We can give oral statements, we can hold side events, and we also can be invited to open meetings of expert committees, such as the Expert Committee on Drug Dependence, which is one of the committees that decides on which palliative care medicines, among other substances, are in the schedules of the UN drug control conventions. And that, again, will be addressed in the advanced course. Excuse me. Our obligation is to present 3-year plans and submit reports to our focal point, who's Dr. Gilles Forte at the Department of Essential Medicines and Health Products. The levels of IAHPC advocacy engagement are international, regional, and national. At the international level, we attend and participate in multilateral meetings as an accredited non-governmental organization with ECOSOC. I've already defined that. In the Commission on Narcotic Drugs, in the Human Rights Council, in the Open-Ended Working Group on Aging, and the World Health Organization. At the regional level, we attend and participate in WHO regional meetings and palliative care congresses. We try to build relationships with the Organization of American States and the Inter-American Drug Abuse Control Commission, because the Organization of American States has a convention which is on the rights of older people, which gives a right to palliative care and controlled medicines. And the Inter-American Drug Abuse Control Commission is the organization that should be improving access to controlled medicines in the Americas. And then we support regional associations on requests, such as ALCP in Latin America, APCA in Africa, APHN in Asia, Carapulca in the Caribbean, and IAHPC in Europe. At the national level, these are some of the things we do. We coach our national partners to advocate with national governments, regional associations, and their UN missions. So what we're trying to do there is increase the sphere of influence of the national partners. And then we mentor designated advocacy ambassadors in 6 specific countries, and we're hoping to expand that program in the next few years. We have a pilot with Argentina, Australia, Bangladesh, El Salvador, Kenya, and Zambia. The cornerstone documents, the texts with agreed language that we use on drugs, as they're called, the Single Convention on Narcotic Drugs, the UNGAS, that's UN General Assembly Special Session on Drugs outcome document, which has an entire chapter on improving access to controlled medicines, and the Ministerial Declaration of 2019, which also discusses access to controlled medicines. In terms of global health, primary health care, and universal health coverage, the key documents are the World Health Organization Constitution, the Astana Declaration, and the political declaration of the high-level meeting on universal health coverage approved in October 2019. The second set of cornerstone documents are the human rights documents, the Universal Declaration of Human Rights, the International Covenant on Economics and Social Cultural Rights, and General Comment 14, which mentions palliative care and says it should not be denied to certain vulnerable populations. The reports of the special rapporteurs, particularly for torture and health and older persons. And then the other cornerstone document is the Inter-American Convention on the Rights of Older Persons and the reports of the independent expert on the rights of older persons. And we'll be going into these documents in much more detail in the advanced course and the particular provisions you can use in your advocacy in your country. So the organization of the following section is we're going to discuss the goals of our advocacy program, the processes, the challenges, the key issues to flag, and the key partnerships. The goals of IAHPC advocacy briefly are that multilateral commitments of member states are propagated into funded national and regional policies. In other words, they're translated from the agreed language in the documents I just cited into national and regional policies. Remember the assumptions we went in the beginning, that language is important. So the second is that palliative care, is integrated into all global health documents as appropriate. The third is that training, service delivery, appropriate prescribing of controlled medicines are included in all primary health care and universal health coverage packages. And the fourth, that national, regional, and international drug policies support adequate access to essential palliative care medicines. So the process is that we participate in multilateral meetings and consultations, and I've given you a list of what those are. This is me participating in the World Health Organization. We support regional and national partners, and we utilize social and conventional media to get the word out about what we're doing at the multilateral meetings. Effective advocacy messaging utilizes evidence and emotion. It's clear about the issue and the ask, and it's analyzed the challenges. So it's done more or less a SWOT kind of analysis of who might be against us, who can support us, what our spheres of influence are, and how we can progress. We don't just get up one day and say, oh, this is a good idea, we should do this because it's a human right. We do all those things in our messaging. Palliative care advocates act as key informants, which is another term that's important because we inform policymakers. We connect them with information, with providers, and with patients. If you remember from the beginning, I said these are the witnesses who give testimonies. We promote integration of palliative care into primary health care as key informants. That's what we do. And we participate in policy discussions about quote unquote drugs, global health, and human rights. In other words, we don't just talk about clinical palliative care. We have to expand our sphere of influence to participate in these other discussions. So we have sometimes one desired outcome of many, which is that countries in these multilateral meetings, and this is just one example at the World Health Organization Executive Board meeting, that they say the words palliative care, because those words are almost never said at the multilateral meetings we attend. It's just not spoken. So when it is spoken, it demonstrates the alignment between the multilateral commitments the member states have made in those texts we've already discussed and national policy. If the representative for your country talks about national palliative care policy, that means there's an alignment. It also increases airtime for the concept of palliative care and the importance of access to controlled medicines. And it improves member states' familiarity with palliative care because most of them don't understand what it is, and I'll talk about that in the challenges, and they don't really understand how it fits into their health policy. Also, when member states say the word at these meetings, it exposes the best practice partnerships between national palliative care associations and ministries in national capitals. So it shows there's that synergy between what you're doing on the ground and with the missions in Geneva, New York, and Vienna who represent your country and speak at these meetings. So that's why we really like to work with the missions as well as the palliative care associations in the countries. This was a big advocacy win we had at the UN at the Open-Ended Working Group on Aging, that's OEWGA, at the 10th meeting. Palliative care and long-term care were on the agenda of that UN meeting, so member states discussed palliative care for older persons and what they were doing in their countries all day. And we had a side event, IAHPC did, with several other partners at the UN and had very important speakers at that. So that was a big advocacy win, as I said. Some challenges of palliative care advocacy, as many of you already know, is the widespread unfamiliarity with palliative care concepts and practices. And that applies to the media, to healthcare systems as a whole, as well as to the general public. So there's lots of education we still have to do. It certainly applies to foreign ministry mission staff, the people in your country's missions, the diplomats, who are even less familiar with palliative care language. Excuse me. And the stigma of palliative care when people are somewhat familiar, they think it's only for end-of-life care or only for cancer, or even, I've heard, euthanasia. There's also the fear of additional costs in the context of hospital-based systems and the association of essential palliative care medicines, such as morphine, with illegal drugs. That's a big challenge we have right now, especially in the narrative of the opioid crisis in the US and Canada, which has increased opioid phobia. We thought we'd made several steps forward, and this opioid crisis is pushing us several steps back. Other challenges are scarce government public resources for health in the neoliberal model, where most resources which used to be public are now privatized. Scarce philanthropic resources to train and fund the travel of regional and national advocates to global meetings. We would like you to come to those meetings, but we often don't have the funds, so you have to be self-funded if you want to come. The good thing at the Commission on Narcotic Drugs meeting is that we can often do videos and teleconference in. A big challenge that I run into at the World Health Organization is the ideology of global health that prioritizes reducing preventable mortality. So you'll always hear the words prevention, control, treatment, but you won't hear palliative care, as I said, which is why even getting delegates to say the words palliative care shows that that ideology of prevention is not going to dominate. And then there's a general cultural unwillingness that many of you are familiar with to talk about serious illness and dying. So if you can't talk about serious illness and dying, it's very hard to talk about palliative care in public at multilateral meetings and say how important it is to have palliative care policies. So the key issues that we flag in all the reports, declarations, and resolutions on universal health coverage, primary health care, and non-communicable diseases, often these documents and reports come across our desk, and we try to flag, do these documents and these discussions include palliative care? Because as I've said several times, it often forgets about palliative care. Is access to affordable, essential, internationally controlled palliative care medicines mentioned where appropriate, or are controlled medicines ignored completely? Is there appropriate reference to the rights of older persons and children to palliative care? Is there a gender perspective? Because often older women are both patients and caretakers, and they're not compensated, they're not skilled, and they carry a much heavier burden. And then, do these documents, declarations, and resolutions respect the rights of prisoners, refugees, and other vulnerable populations as per the different documents that prioritize those marginalized and vulnerable populations? And the Lancet Declaration, which was the action component of the Lancet Commission report on pain and palliative care, which names all these populations that are entitled to palliative care. As we're moving along, we're going to talk about who the key government and official stakeholders in our advocacy collaborations are. And these are the policymakers in your countries, in the UN member states. These are the people who work in the national ministries as administrative staff, as well as the political appointees. So the civil servants as well as the ministers, they are government stakeholders. And then also the diplomats at the national missions in Vienna, Geneva, and New York. Those are the UN offices. They are usually appointees of the foreign affairs or external relations ministries. They are very rarely health ministry appointees. So they know even less about palliative care. And then you have the official secretariat staff of the UN organizations, which I discussed at the beginning. So these are the official governmental stakeholders that all of you who are doing advocacy need to start making contact with to expand your sphere of influence. The key non-governmental collaborators are the national, regional, and international palliative care associations, the patient organizations, and then patients and families. The other non-governmental organizations with common interests, and I'm thinking here of organizations that represent people with non-communicable diseases, including cancer, people with disabilities, older persons, indigenous persons. There are many non-governmental organizations that you can start partnering with because they also have an interest in palliative care once that is flagged. Academia plays a large role in our advocacy strategy, such as the University of Miami, which led the Lancet report. And most of our board members are affiliated with academic institutions. Policy experts and think tanks, not necessarily palliative care people, but global health people. Faith communities, very important because that's where the patients and families can be found. And traditional social media contacts, traditional and social media contacts, who you need to cultivate in order to get the message out. So what I'd like you to think about is, does your association's strategic plan, hopefully you have one, include advocacy? Is the language, if you have it, operational? Is it aligned with your vision and mission statement? And do you have an identified advocacy focal point with a deputy? Because this is a slightly specialized role, which isn't necessarily coextensive with a clinical role. And it needs to be someone who I can be in contact with to let that person know what's happening at the multilateral level, how you can contribute, how you can communicate with your missions, etc. It's important to have somebody identified as a focal point in your national and regional organizations. And then, do you have advocacy targets and outcomes, such as we want to develop a policy, we're trying to develop a budget, we're going to have a national day in October, include our minister, and do you have a way to evaluate that? And last but not least, can you celebrate successes and evaluation challenges? So it's really important to know if you can evaluate what you've been doing. So some questions to help you build your advocacy program for your association. Just start thinking about who you want to influence, and you'll make a list of ministries who you need to influence, which will probably include Ministry of Education, different medical schools, maybe some policy organizations, faith organizations. Who will you work with? And then identify people as well as contact information. Which advocacy strategies will you use? And of course, we can help you with that. Can you use patients and families as key informants, which we totally recommend because they are your key witnesses? Will you educate the media? Will you prioritize health worker training? These are all different priorities which will depend on the skills available to you as well as your sphere of influence and how you think you can expand that. Then, of course, as I said earlier, how will you measure and evaluate the outcome? And how will you hold your government accountable? That's why it's so important to build relationships between a focal point in your organization and a focal point in the government. Just winding up here, I'm going to talk about the IAHPC relationship to other global organizations that do advocacy for palliative care. In 2019, we approved the Berlin Declaration, which announces advocacy collaborations between the three global organizations, IAHPC, WHPCA, the Worldwide Hospice Palliative Care Alliance, and ICPCN, the Children's Palliative Care Network. And we've got a very rough division of labor. There's a lot of overlap, but IAHPC is going to focus mostly on access to controlled medicines, rights of older persons, primary health care, global health, and integration of palliative care into global health. And of course, we have our monthly newsletter reporting, which I hope you're all subscribed to. And then the WHPCA, their main areas of focus are universal health coverage, non-communicable diseases, World Hospices and Palliative Care Day, and they produce the wonderful eHospice. And ICPCN, of course, focuses mostly on children and access to essential medicines for pediatric palliative care with an annual congress. So this is a list of selected resources. If you want more resources, please feel free to contact me. But these are just some of the basic ones for the multilateral framework, the human rights organizations and documents, the agreed language, and all the concepts we've learned about in this basic course. So thank you for your attention, and I really look forward to your feedback, and I hope you will consider taking the advanced course, which we will be letting you know about early in the new year.